Hello and welcome to another video brought to you by Atoza. My name is Garth. In this video, we're going to be discussing the essential components of cardiovascular physiology for the safe provision of anesthesia by the trainee anesthetist. All forms of anesthesia have cardiovascular side effects. In young, healthy patients, these side effects are usually mild and easily managed. In patients with significant medical illnesses, or when complications of anesthesia occur, the effects can be more severe and more complex to manage. Surgery itself can also have significant cardiovascular side effects, and a big component of anesthesia is anticipating these side effects and attenuating them. So then, as anesthetists, the better our understanding of cardiovascular physiology, pathophysiology in disease, and consequences during anesthesia and surgery, the more equipped we will be to safely care for our patients. During this talk, we will attempt to take complex physiology theory and simplify it into core areas of understanding that can be applied in daily clinical practice. Let's start by looking at the end point of the cardiovascular system. We all know that oxygen is essential for keeping us alive. But why is that? Why is it so essential? Oxygen is essential for almost every cell in the body as it plays a crucial step in cellular respiration. Cellular respiration is how cells derive energy. Cells need energy to keep themselves healthy, such as to maintain ionic gradients across their membranes, to divide and grow, and to perform the individual functions specific to the tissues that they are a part of. Cellular respiration in the presence of oxygen is called aerobic metabolism. Aerobic metabolism generates large quantities of ATP, and ATP is the energy storing molecule which can be used throughout the cell where needed. So, oxygen is needed in cellular respiration to generate large quantities of ATP. We can take a look at this picture of glucose metabolism inside the cell. We see that once glucose is converted to pyruvate in the cytoplasm, the pyruvate can then enter the mitochondria. The mitochondria is the energy factory within the cell. Once the pyruvate is inside the mitochondria, it can undergo Krebs cycle. Energy is released from the Krebs cycle and carried by energy transport molecules to the mitochondrial membrane. The energy at the mitochondrial membrane is used in the electron transport chain to generate ATP. And it's oxygen here that is the final electron acceptor in this process when it combines with hydrogen to form water. In this process, the mitochondria are able to generate large quantities of ATP from each original glucose molecule. Without oxygen to perform this crucial last step in the electron transport chain, there is a major traffic jam in the mitochondria, preventing further activity in the Krebs cycle. The technical explanation for this, just for interest's sake, is that all the energy transferring molecules like NAD and NADP already have hydrogen bound to them, and they cannot release the hydrogen into the electron transport chain, which means that Krebs cycle cannot continue. So, no oxygen means no Krebs cycle. Cellular respiration in the absence of oxygen is called anaerobic metabolism. In this next picture, we see that when Krebs cycle is blocked in the mitochondria, pyruvate cannot enter the mitochondria. The pyruvate remains in the cytoplasm and is converted to lactate. You may ask, why the need to form lactate? Well, as seen in the picture, when glucose is converted to pyruvate, some ATP is formed, but this requires the availability of the energy transport molecule NAD. The conversion of pyruvate to lactate frees NADH back to NAD, which is needed for glycolysis to continue. In this situation, the formation of lactate isn't the enemy. It is the solution. It's allowing life to continue. Clinically, lactic acidosis is a sign of anaerobic metabolism. So now we see why anaerobic metabolism is bad. Anaerobic metabolism generates significantly less ATP per glucose molecule than aerobic metabolism. In fact, it generates 95% less energy, which is a significant problem. Anaerobic metabolism, though, is also essential for life. For example, muscles can go anaerobic metabolism for short periods of time. Anaerobic metabolism still does generate some energy during times of oxygen depletion. If anaerobic metabolism persists for long periods of time, there becomes an energy deficit within the cell, with energy demand exceeding energy supply, and cellular damage or cell death can occur. A state of inadequate oxygen at a cellular level is called hypoxia. The next question in understanding the essence of life is, how does oxygen get to the cells? Well, firstly, we breathe. The lungs and ventilation are a means of bringing oxygen within close proximity to the blood so that it can enter the blood. In the next picture, we see an alveolus which is undergoing gas exchange with a capillary in the lung. You can see that the distance between the air in the alveoli and the blood is extremely small. In fact, it's just the single cell layer of the alveolus and the single cell layer of the capillary wall that separates them. There is another tutorial in this series where we cover respiratory physiology in detail. So firstly, we said we need to breathe. Secondly, we have a circulatory system. The blood in the circulatory system is the medium for carrying oxygen within the body. Approximately 98% of oxygen in the blood is transported bound to hemoglobin in the red blood cells. That's a significant thing to think about. 98% of oxygen is actually connected to hemoglobin in the red blood cell, and only 2% is dissolved in the blood itself. We will be covering the physiology of blood in later tutorials in this series. The cardiovascular system is the means of circulating blood within the body so that it can collect oxygen from the lungs and deliver oxygen and other nutrients to the tissues and organs for cellular respiration. The cardiovascular system is also responsible for the collection of waste products from the tissues and delivery of those waste products to various organs for elimination. As we can see in the next image, one of the main waste products of aerobic metabolism is carbon dioxide, which is transported, dissolved in the blood, back to the lungs for elimination in the form of expiration and ventilation. And in this, we have uncovered the main function of the cardiovascular system, which is the delivery of oxygen and other nutrients to the cells to sustain life, and the transport of waste products from the cells to various organs for elimination. It's pretty cool to simplify such complex systems such as ventilation and the circulatory system into this simple idea. You may have picked up now that I've used the word delivery a couple of times. The word delivery implies movement. This movement is, of course, blood flow, which brings us to a key term in our understanding of cardiovascular physiology, that is, flow. So, oxygen delivery to the tissues is essential for life, and oxygen delivery is dependent on two factors. Number one, the amount of oxygen in the blood, and number 2, the amount of blood flow. Flow is described in liters per minute. It is a measure of volume per unit time. In other words, it's the actual amount of blood going past a point over a set time. To understand flow better, we need to take a few steps back and look at the absolute basics of the cardiovascular system. To begin with, we will reduce the whole complex circulatory system to a simple system involving a pump, pipes, and fluid, as shown in this diagram. The success or function of the system is equally dependent on all 3 components: the pump, the pipes, and the fluid. Let's start by looking at the pump. For the system to work efficiently, the pump itself needs to be in good working order. This includes components like a working electrical system and energy supply, a pumping chamber that is unblocked and able to receive fluid, an impeller or motor that is working well and able to handle its workload. The pump, of course, can only pump the fluid that fills it. If the pump is empty or half full, its function will be worse. So we can say its function depends on the fluid filling it. The pump can work at different speeds or strengths to create more pressure and flow. The pump also has to work against the resistance of the pipes by forcing fluid into the pipes. It's obvious that if the pump weakens or fails for any reason, the overall success of the system is reduced. Now let's look at the pipes. The pipes too need to be in good working order for the system to succeed. This includes aspects like being the correct diameter or size to carry the amount of fluid in the system. They need to be wide enough to allow easy flow of fluid, but not so wide that the fluid can fill them without flowing. As can be seen in the diagram, there are pipes carrying fluid away from the pump and pipes carrying fluid back to the pump. They are all equally important. It's clear that pipes that are too narrow or too wide or are leaking will severely affect the success of the system. Lastly, let's look at the fluid in the system. The whole purpose of the system is to pump the fluid. This is why the system exists. The fluid is essential for the system to fulfill its purpose. Remember that the pump can only pump the fluid that fills it, so any reduction in the fluid returning to the pump will significantly impair the pump's performance. This model of the pump, the pipes, and the fluid is an excellent starting point to understand the cardiovascular system, and one I return to when trying to work out how best to manage patients with cardiovascular or circulatory problems. We do need to understand the cardiovascular system in more detail though too. So let's get into that now. The cardiovascular system is made up of the same pump, pipe, and fluid model, except we have 2 of these systems in series: the right side of the heart and the pulmonary circulation, and the left side of the heart and the systemic circulation. As this tutorial series is aimed primarily at trainee anesthetists, we will spend most of our time focusing on the systemic circulation. But that isn't to say that the pulmonary circulation and the right side of the heart is not important. Both circulatory systems need to function adequately to not affect the other system and the overall function. In fact, disorders of the right heart and pulmonary circulation can be extremely challenging to manage in anesthesia and in critical care medicine. As we take a more detailed look at the circulatory system, let's begin with the heart. In the body, the right ventricle and left ventricle are each a pump. Their function is to generate a force or pressure that squeezes blood from within their chambers into the pulmonary and systemic arterial system. The function of the heart pump as a whole is dependent on, number 1, preload, and by preload I mean volume. The volume of blood that fills the ventricle. The heart can only pump what is in it. Number 2, preload, but now I'm talking about strength. Up to a certain point, the more volume that fills the heart, the greater the strength of each contraction. This is Starling's law. So preload has 2 components where it affects heart function. Number 1, there actually has to be blood in the heart to pump. And number 2, as more blood enters the heart actually acts more strongly. Number 3, contractility. The strength of each contraction is also under the control of the sympathetic nervous system via nerves from the sympathetic chain and also circulating catecholamines from the adrenal glands. To understand contractility, one must appreciate that at the same preload, at the same volume that has filled the heart, the force of contraction can increase or decrease in response to the factors mentioned above. For example, when we exercise, our heart will pump harder and eject more blood per beat than when we are at rest. In fact, our resting flow from the heart can increase from 5 liters per minute to about 20 liters per minute during exercise. That is quite amazing. We will come back to flow later. Number 4, the function of the heart is also dependent on heart rate. This is the speed of contraction, relaxation, and the number of contractions per minute. The speed of contraction, the speed of relaxation, and the number of contractions per minute are all under control of the autonomic nervous system. The parasympathetic nervous system, via the vagus nerve, slows down heart rate via the sinoatrial and atrioventricular nodes. The sympathetic nervous system, via neural and hormonal input, can increase the frequency of beats as well as speed up the rate of contraction and relaxation. Faster heart rate means more pumping per minute. Number 5, afterload. This is the pressure that the ventricle must generate before any blood flow can occur. This pressure is required to overcome the resistance opposing blood flow out of the heart. Number 6, the structural function of the heart. The various anatomical components of the heart can significantly affect overall function of the heart. This includes all the anatomy of the heart, the membranes surrounding the heart, which is called the pericardium. For example, pericarditis or inflammation of the membranes surrounding the heart can prevent the heart from filling during diastole, the fluid between the pericardium and the muscle wall of the heart. Pericardial effusions can also compress the heart and impair its function. The wall muscle of the heart, which is called the myocardium. Myocardial infarctions can cause parts of the muscle of the heart not to function and so worsen contractility. The one-way valves within the heart that prevent flow in the wrong direction. An aortic heart valve that cannot open completely, called aortic stenosis, creates significant resistance to the flow of blood out of the ventricle. The electrical conduction system in the heart. This can affect heart rate and coordination of contraction. And so we see that the actual anatomical structure of the heart also significantly contributes to the overall function of the heart. So to summarize, the function of the heart is dependent on preload, both the volume within the heart and the effect that this volume has on contractility, itself, heart rate, afterload, and the actual structural function of the heart. Now let's look at the pipes. The arteries and veins and capillaries are the pipes. When the heart contracts in systole, it generates a pressure in the ventricles that forces blood into the large arteries under pressure, so there is flow of blood. These large arteries have predominantly elastic walls and so stretch outwards with the pressure to accommodate the volume of blood that has flowed into them. When systole ends, blood flow from the left ventricle stops, and the diameter of the large arteries decreases again under elastic recoil. This maintains the blood pressure within the larger arteries and creates a pulsatile wave of energy along the large arteries. This also forces the aortic valve closed under back pressure. This phenomenon of elastic stretch and elastic recoil within the large arteries is called the Windkessel effect, and it is responsible for maintaining diastolic blood pressure and for generating more continuous blood flow in the arteries, as opposed to flow only during systole. For this elastic dilatation and recoil to occur in the large arteries, there needs to be a resistance to blood flow in the arterial system. If there was no resistance, the blood would enter the pipes and lose its pressure immediately. Just like water coming out of a garden hose, low resistance means low pressure. By creating resistance to the flow of water with one's finger at the end of the pipe, a higher pressure is generated. You can feel this pressure with your finger on the end of the hose, and you can see it in the distance the water sprays from the hose. So, all pipes have a resistance to the liquids that flow in them, and the arteries are no different. The resistance is a consequence of contact of the blood with the lining of the artery itself, but also, and most importantly, due to the diameter of the vessels. This is mostly controlled at the level of the arterioles. The resistance to blood flow in the systemic circulation is known as systemic vascular resistance. As said, the smaller arteries, called arterioles, have more smooth muscle in their walls, which, like the heart, is under the control of the autonomic nervous system and also local factors. Beta-2 adrenergic receptors from the sympathetic nervous system, under the influence of adrenaline or noradrenaline, cause vasodilatation. That means opening up of the arterioles. Alpha adrenergic receptors, under the influence of adrenaline or noradrenaline, cause vasoconstriction, that is, narrowing of the arterioles. The renin-angiotensin-aldosterone system from the kidneys causes vasoconstriction. Local products of metabolism and/or inflammation, such as nitric oxide, also control vascular tone. In some systems, the arterioles even adjust their own muscle tone in response to the blood pressure itself, a phenomenon known as autoregulation. This ability of the arterioles to constrict or dilate affects the overall systemic vascular resistance, and it alters blood flow into that tissue or area. Let's summarize some of what we have discussed thus far about the pipes. Large arteries are elastic for distension and recoil to maintain blood pressure and to change pulsatile flow into more continuous flow. Smaller arteries, called arterioles, have adjustable smooth muscle tone so that they can change diameter. We now find ourselves asking, what effects do arterial tone and systemic vascular resistance have on the circulatory system? Firstly, systemic vascular resistance is essential for the generation of blood pressure. Secondly, it controls local organ perfusion. Thirdly, It results in fluid shifts between the vascular and extravascular compartments. So let's now recap on how arterial tone and systemic vascular resistance has these three effects. Firstly, let's look at blood pressure. As we said earlier, when the heart pumps and ejects blood into the large arteries, that blood meets an opposition to flow, which is partly because of the resistance that the pipes themselves offer, but mostly because of the narrowing of the pipes that happens distally at the level of the arterioles. This is what generates the greatest resistance in opposition to flow. This resistance to flow is what enables the flow of blood out of the heart to generate a blood pressure within the pipes, the systolic blood pressure. This pressure forces the large arteries to expand because of their elasticity. And then when the heart relaxes, there is elastic recoil, and the large arteries then narrow again, and this maintains blood pressure, which is the diastolic blood pressure. A system where fluid is pumped into pipes that offer little or no resistance to the flow of that fluid looks similar to this picture. And it's a useful way to remember this concept. Let's now discuss how arterial tone can affect tissue perfusion. In this diagram that I created with very little artistic skill, but a lot of determination, I've depicted three different physiological states using the three different shapes and colors which represent the tissues. So if we start with the yellow physiological state, this is a state where the arterial tone is high. There's vasoconstriction of the arteriole smooth muscle, and because of that, we can see that capillary flow to the tissues in this state is low. Next, if we look at the green shape representing a different physiological state, in this case, normal physiology, where the arterial tone is normal, you can see that the capillary flow to the tissue is medium or normal. And then lastly, if we look at the blue shape, which represents third physiological state and blood flow to that tissue, here the arterial tone is low. The smooth muscle in the arterioles is dilated, and that means that there is high capillary flow to the tissues in this state. So this is just a very simplified way of showing how arterial tone in different physiological states can affect capillary blood flow to the tissues. Lastly, let's look at how arterial tone or vascular resistance can affect fluid shifts between the intravascular compartment and the extravascular compartment. So I've created another two amazing works of art to describe this phenomenon. In the first diagram, I've represented a state of high or higher arterial tone, which means that there is a greater resistance to blood flow through those arterioles. And so those arterioles limit blood flow into the capillary network that they feed into. And so that capillary network within the tissues is under low pressure relative to the fluid pressure of the tissues themselves. And in this state, then, I've depicted fluid moving from the interstitial space in the tissues into the lower pressure capillary network. And so the capillaries are actually going to drain fluid or take fluid from the tissues and return that to the circulation via the venules and the veins. And a classic example of this would be in severe hemorrhage, where there is a drop in systemic blood pressure, and that will result in a stress response with the release of adrenaline and noradrenaline. And we know that those agents are going to cause vaso and venoconstriction, and so the arterial smooth muscle tone is going to go up, the systemic vascular resistance is going to go up, and because the arterial tone has gone up, blood flow through the arterioles into the capillaries is low. And so the pressure within the capillaries is low, and that's why fluid can move from the interstitial space into the capillaries and return to the systemic circulation. And this is a fantastic physiological response that the body has to try to maintain blood volume and blood pressure by redistributing fluid from the extravascular space into the intravascular space. The second diagram that I've drawn represents a more normal physiological state where the arterial tone is balanced and capillary pressure is normal. And so there is a balance between fluid pressure in the capillaries and the interstitial pressure within the tissues. And so there is no net movement in either direction, and this would represent a healthy state during normal daily living. Moving on now. In between the arteries and the veins are the capillaries. But let's cover the veins first. The veins are the pipes that are responsible for blood flow back to the heart. The pressure in the veins is significantly lower than the pressure in the arteries. In fact, the average pressure in the veins is around 8 millimeters of mercury, compared to the average pressure in the arteries, which is around 80 or 90 millimeters of mercury. The veins have the potential to dilate and hold large volumes of blood, which can significantly reduce blood flow back to the heart. In fact, about 70% of the total blood volume is in the veins at any one time. It's not 50-50 with the arteries as one would expect. Veins are also under the control of the autonomic nervous system, and their tone and diameter can change, and so alter blood flow within them and blood storage within them. This is mediated by sympathetic nervous system control via alpha receptors. Venous return to the heart is aided by a couple of factors. The skeletal muscle pump, which is muscle contraction in your arms and legs, forces blood back towards the heart. The respiratory suction effect, that is negative intrathoracic pressure when you breathe in, pulls venous blood back to the heart. The heart suction effect, when the heart pumps, it empties its chambers, and during diastole, this helps to draw blood back towards the heart. Venous return is also affected by venous wall tone, as mentioned above, which is under sympathetic control. There are also valves in the venous system to prevent backflow. Venous return to the heart may also be impaired by poor cardiac function, high intrathoracic pressures, and gravity. And so now, having looked at the arteries and the veins, we finally come to the capillaries. Capillaries have a very large cross-sectional area, and so they have a very low resistance to blood flow. This is because of the sheer number of capillaries that we have in our body. Capillaries are low-pressure systems with slow blood flow. Each capillary has a very small diameter, so the red blood cells, which are carrying oxygen, are in close proximity to the cells of the tissue. The slow blood flow and the close proximity of the red blood cells to the tissue is the perfect condition for the movement of nutrients, waste, oxygen, and carbon dioxide between the blood and the cells of the organs. The capillary network is what we call the microcirculation. The precapillary arterioles, remember the ones that we spoke about with the smooth muscle that can dilate and constrict, control blood flow according to their smooth muscle tone. Arterial smooth muscle tone is under the control of numerous mediators and factors. Firstly, sympathetic outflow, where stimulation of beta-2 receptors causes vasodilatation, and stimulation of alpha receptors causes vasoconstriction. Then the renin-angiotensin system, which is mediated via the kidneys. Vasopressin and natriuretic peptides also have an effect. Mediators released by platelets in tissue damage affect tone, and they normally cause vasoconstriction to reduce blood flow to the damaged tissues. Inflammatory mediators also affect tone. They tend to cause vasodilatation to increase blood flow to the tissues. Nitric oxide, in response to metabolic demands, has an effect on the smooth muscle tone, causing vasodilatation to increase blood flow to the tissues in times of high metabolic demand. And then the smooth muscle tone is also under the effect of autoregulation. So, having now covered the pump and the pipes, we move on to the fluid. Blood is the fluid of the circulatory system. It is responsible for transporting the many substances essential for life, including oxygen. The system can only circulate the fluid that it has, and so maintaining a normal blood volume is very important. There are more characteristics of blood that are extremely important and will be looked at in later talks. Let's move on now in our understanding of basic physiology and look at blood pressure. When the left ventricle of the heart contracts, it generates a pressure within its cavity. This pressure forces the mitral valve closed so that blood cannot escape backwards into the atrium. The pressure rises within the left ventricle until the aortic valve opens. Blood then flows from the left ventricle into the aorta, and as it flows, the ongoing contraction of the left ventricle continues to increase the pressure. This generates the systolic blood pressure of, say, around 120 millimeters of mercury. The left ventricle then starts to relax, and the pressure within its chamber starts to drop. As such, with the aortic valve still open, the pressure within the aorta drops too. At some point, the aortic pressure is higher than the left ventricle pressure, and the aortic valve closes, preventing backflow of blood from the aorta into the left ventricle. Because of the elastic recoil of the aorta and the other arteries, the pressure doesn't drop too low though. Normally, it drops to around 80 millimeters of mercury before the next contraction of the ventricle occurs. The pressure generated by the ventricle and the elastic recoil of the artery causes a wave of pressure and flow down the arterial tree, which is measured by us using a blood pressure monitor. That is blood pressure. Blood pressure is changing all the time with systole and diastole. So, from an organ perfusion point of view, we are actually most interested in the average blood pressure over the cardiac cycle, which is called the mean arterial pressure. You may remember that the equation for mean arterial pressure is a third of the difference between the systolic blood pressure and the diastolic blood pressure added to the diastolic blood pressure. From now on in this talk, if we refer to blood pressure, we are actually referring to mean arterial pressure, because that is what determines blood flow. Blood pressure is created by and dependent on two variables. Firstly, the cardiac output. The heart has to be pumping out blood for there to be a blood pressure. The more blood pumped out, the greater the chance of generating a pressure. And so, blood pressure is directly related to or dependent on cardiac output. Number 2, resistance. There needs to be an opposition to the flow of blood ejected by the heart to generate a pressure or to maintain the pressure. This resistance is called systemic vascular resistance. The higher the resistance to blood flow, the higher the pressure generated. So, blood pressure is also directly dependent on systemic vascular resistance. And hence, we have the classic equation that says that blood pressure equals, or blood pressure is dependent on, cardiac output times systemic vascular resistance. In other words, blood flow out of the heart meets an opposition to the flow, and this generates a pressure. Cardiac output, which is the blood flow out of the heart itself, is dependent on the volume of blood ejected with each beat, which is called stroke volume, and the number of beats per minute, in other words, the heart rate. Hence the equation cardiac output is equal to heart rate times stroke volume. Heart rate is relatively simple to understand, but just to emphasize, it is heart rate and rhythm. The heart needs to be beating in a coordinated manner to be effective. Also, that faster heart rates aren't always better. There comes a point when the heart is beating so fast that there is no time for it to fill, and so the stroke volume actually decreases. There are numerous variables that affect stroke volume. We went through them earlier: preload, contractility, afterload, and the structure-function relationship of the heart. Okay, so now we understand cardiac output, blood pressure, and resistance. But what about blood flow? The relationship between potential, flow, and resistance is described by Ohm's law, where flow is equal to potential divided by resistance. Flow is created by a potential difference. Flow is limited by resistance. Within the macrocirculation as a whole, systemic blood flow is equal to the pressure difference divided by the resistance. The pressure difference being the mean arterial pressure minus the mean venous pressure divided by the resistance, which is the systemic vascular resistance. In other words, what this equation is saying is that the pressure on the arterial side of the system, the mean arterial pressure, minus the pressure on the venous side of the circulation, is what creates the potential difference, the potential for flow. And this flow is limited by the resistance in the system, which is the systemic vascular resistance. Although for most explanations, it is simply written systemic blood flow is equal to mean arterial pressure divided by systemic vascular resistance. And this is because the mean venous pressure is normally so much lower than the mean arterial pressure that it doesn't play much of a role in this equation. So these are three clinical examples that I have quite frequently come across either in my anesthetic work or when I'm covering the intensive care unit. And what I'm trying to illustrate is how, despite the fact that the blood pressure and heart rates in all three of these patients are very similar, the circulatory status of each patient is extremely different in terms of flow, pressure, and resistance. So the first example on the left is a patient with acute pyelonephritis, and the heart rate for this patient is 140 beats per minute. The blood pressure is 85 systolic over 40. The patient is febrile and sweating. The patient has hot peripheries, bounding pulses, but has poor urine output. The next patient in the middle is an elderly patient who's having an acute myocardial infarction. Here, the heart rate is 120. The blood pressure is also 85/40. This patient's peripheries are cold and clammy. The radial pulses, when you try to palpate them, are weak, and the patient too is not passing urine. And the third patient on the right is a patient who's having a postpartum hemorrhage. Her heart rate is 140 beats per minute. Her blood pressure is also low at 85/40. She has cold peripheries. She is not passing urine, and she too has weak radial pulses. So if one was to just look at the vital signs on the monitor next to the patient, these patients look quite similar. Blood pressure, 85/40, and tachycardic. But what's going on inside the patient is very different. So now let's add some explanations. Back to the patient on the left with the pyelonephritis. Hypotensive, tachycardic, with warm peripheries and bounding pulses. In this patient, the cardiac output is likely high. She has bounding pulses, she's tachycardic, and we know that in early septic shock, cardiac output is normally increased. The cardiac output is high, but the patient is vasodilated because of the sepsis. And that combination of high cardiac output and low systemic vascular resistance is what has resulted in the low blood pressure. She also likely has low intravascular volume. And again, we know that in sepsis there is leaking of fluid from the intravascular space into the interstitial space, and also often sick patients become dehydrated because they're not able to eat or drink. Despite the high cardiac output and the vasodilated state, there is evidence of poor tissue perfusion. We can tell this because her urine output is poor, and so actual blood flow to the kidneys and probably other tissues in the body is poor. Then the patient in the middle, the older patient is having the acute myocardial infarction with a low blood pressure, tachycardic, but cold, clammy peripheries. In this patient, the cardiac output is likely low because she's having a heart attack. The patient is likely vasoconstricted. We can tell this because the peripheries are cold and clammy. Her blood volume is normal because she is unlikely in this acute event to have become dehydrated, and she hasn't been bleeding, so she has a normal blood volume. She too has poor tissue perfusion because she is not passing urine. So a low cardiac output state with vasoconstriction has resulted in poor tissue perfusion. And lastly, the third patient on the right, the lady with the postpartum hemorrhage, hypotensive and tachycardic with cold peripheries. Her cardiac output is low because of hypovolemia. She has poor venous return to the heart, reduced preload, and underfilling of the ventricles. She is likely vasoconstricted. We can tell this because her peripheries are cold, and we know that this is the body's response to acute severe hemorrhage to try to maintain systemic blood pressure. She too has evidence of poor tissue perfusion, as evidenced by a poor urine output. So in summary, these three patients have very similar vital signs in terms of blood pressure and heart rates, but very different underlying circulatory characteristics when we think about cardiac output, systemic vascular resistance, blood pressure, and blood flow. So you may have noticed that earlier I said that within the macro circulation then, blood flow is equal to mean arterial pressure divided by systemic vascular resistance. This is because we were emphasizing systemic blood flow. But how do we assess or understand blood flow within the microvascular system, or at an individual organ or tissue level. Within the microcirculatory system, there are regulatory mechanisms, as described previously, to try to maintain tissue perfusion in the face of variations in blood pressure, and this is done by altering resistance. Unfortunately, and also fortunately, the microcirculation often suffers to support the macrocirculation. This is because not all organs are created equally. From a survival point of view, our physiology is biased towards preserving blood flow to the heart, the lungs, and the brain. This makes total sense. The brain needs to function to allow consciousness and bodily function. The heart and lungs need to function to keep the body alive. All the other organs can suffer periods of neglect with less immediate negative consequences. Perfusion or oxygen delivery to the heart, the lungs, and the brain is largely dependent on the macrovascular variables. For example, the coronary arteries arise immediately from the proximal aorta to perfuse the hard-working myocardium. The carotid arteries arise from the aortic arch, and brain perfusion is largely protected within mean arterial pressure ranges of 50 to 150 millimeters of mercury. That's not to say that these organs don't also have a microcirculatory component, but the adaptive response of increasing systemic vascular resistance at the cost of having areas of poor microcirculatory perfusion to maintain blood pressure make total sense. The last section to cover in this talk on the essentials of the cardiovascular system is control of the cardiovascular system. And this control occurs via a complex interplay between multiple physiologically monitored variables and then responses by multiple organs. The primary center for control is in the hypothalamus, which receives multiple inputs. These inputs include those from baroreceptors in the carotid body, which measure your blood pressure, mechanoreceptors in the atria and ventricles of the heart, peripheral chemoreceptors, input from the cortex, such as cognition and emotion, and other inputs too. The output from the control center in the hypothalamus is via the autonomic nervous system. Sympathetic outflow in response to low blood pressures affects the vasculature, the adrenals, the kidneys, the heart, and other organs. Parasympathetic outflow in response to high blood pressure primarily slows down heart rates and conduction via the vagus nerve, and it is also accompanied by the absence of sympathetic outflow. Let's also look at some of the other organs and systems involved in control of the cardiovascular system. The adrenal glands play a role by releasing adrenaline into the bloodstream under sympathetic activation, and aldosterone into the bloodstream under activation from the renin-angiotensin system. The kidneys also play a role. Sympathetic outflow from the hypothalamus affects renal blood flow and decreases the glomerular filtration rate, which reduces the formation of the ultrafiltrate and essentially reduces urine production. The kidneys also activate the renin-angiotensin-aldosterone system in response to low ultrafiltration rates. Aldosterone from the adrenal glands stimulates the reabsorption of sodium and water in the kidney, and antidiuretic hormone from the pituitary gland stimulates the reabsorption of water in the collecting ducts. The role of the pituitary gland in the control of the cardiovascular system is mainly via the release of antidiuretic hormone from the posterior pituitary, which is released in response to low plasma osmolality, but also in response to a baroreceptor-mediated reflex, in other words, to low blood pressure. This antidiuretic hormone, which is released, stimulates vasoconstriction in the vasculature, and it stimulates the reabsorption of water from the collecting tubules in the kidney. The heart, although primarily an effect site of the cardiovascular system, also contributes to control of the cardiovascular system. In response to sympathetic stimulation, there is increased inotropy, chronotropy, dronotropy, and lusitropy, which means that the heart beats faster, it beats harder, it relaxes faster, and conduction within its electrical system is faster. The effects of the parasympathetic input is firstly the absence of sympathetic input, and secondly, a slowing down of heart rate and electrical conduction. The atria and ventricles have mechanoreceptors that respond to stretch and filling of the heart, and these feed into the control center in the hypothalamus. And then lastly, the vasculature, which is also primarily an effect site of cardiovascular system control. Sympathetic outflow causes vasoconstriction in most circulations under alpha effect, and there is also vasodilatation in some systems under beta-2 effect. The vasculature is also affected by angiotensin II from the renin-angiotensin system, which is activated by the kidney. Angiotensin II causes vasoconstriction, and then vasoconstriction is also caused by vasopressin, which is released from the posterior pituitary gland in response to baroreceptors detecting low blood pressure. The vasculature is also affected by multiple local mechanisms, including tissue damage, inflammation, coagulation, and the metabolism within the tissues. So that is a summary of control of the cardiovascular system. It doesn't cover all aspects, but it gives you insights into the major contributors and also shows you how the cardiovascular system is closely linked to the central nervous system, hormonal systems, and the kidneys. In summary, during anesthesia or in clinical medicine in general, one needs to think of the cardiovascular system at multiple levels. What is happening to the pump, the pipes, and the fluid? What is happening to cardiac output? Then also, what is happening to systemic vascular resistance? Is the blood pressure acceptable? Does the blood pressure mean good flow, or is the blood pressure reading misleading? What is happening in the microcirculation? Is there evidence of poor organ perfusion? This approach will mean your treatment steps are appropriately directed. I hope that you have found this video on the essentials of the cardiovascular system interesting and helpful. As always, we really do want to hear your feedback, so please send us any comments, questions, or suggestions via email, and we hope you enjoy watching the rest of this video series.